Hello everyone, my name is Dr.Giordani from São Paulo, Brazil, and it's a big pleasure to be here talking with you about a very important procedure, which is the crown lengthening procedure. This will be the main topic in this presentation, and it's really nice to talk about this because this is a very important procedure in our daily routine here in Brazil. And I know that this is something that sometimes the clinician has some doubts about it. How can we perform in a very safe way? How can we do in a very easy way? And I will try to use this presentation to talk a little bit about the biological considerations and also try to show a digital way to do it, to perform this in a very safe way. And I really use this every day in my clinic because it makes my surgery easier, cleaner, and faster. And I really like this kind of digital workflow for this kind of procedure, so I want to share a little bit with you guys. I hope you enjoy, and it's a pleasure for me to be here. So first, it's really important to understand that this procedure, it's really common in a clinic because it's really important to relate the soft tissue with the wide aesthetic. I mean, if you have a prosthetic restoration or if you have a natural teeth, it's really important to have a very good transition zone between this natural teeth or prosthetic restoration and the soft tissue, because when you have a very good transition zone, you have a very natural smile, and this combination between natural teeth, I mean white aesthetic and pink aesthetic, develops a very good smile for the patient. And it's really important to understand that the crown lengthening procedure is sometimes the key for a nice smile. And this nice smile, this nice transition needs to be related to the face of the patient. So it's very important to understand that when we align the soft tissue, when we align the gingival margin, we try to align as much as we can related to the upper lip. And when you want to align the smile curve, I mean the prosthetic part, the wide aesthetic, we need to align this related to the lower lip, so we can create a nice smile for the face of the patient. So let's move forward and talk a little bit about the gummy smile diagnosis, so we can go and talk a little bit about the crown lengthening procedure. So gummy smile is something really common in the clinic, and we can have different kind of gummy smile diagnosis. I can have a problem with the bone, I can have a problem with the lip, I can have a problem with teeth. And it's important to understand the different kind of diagnosis to create the perfect treatment plan, to select your treatment option to solve the gummy smile problem. If I have a problem with a vertical maxillary bone access, I mean when the patient comes to you with a gummy smile and you go for the exams to solve to create your diagnostic and to select your treatment option. When the patient comes to you with a vertical maxillary bone access, I mean when the patient has a maxilla that grows too much, it's one kind of treatment that we can offer to this patient. Most of the times we move to orthodontic surgery, most of the times we move to ortho treatment. So how can we use our diagnostic tool to understand the vertical maxillary bone axis? First of all, we need to take a picture of the patient. So you ask to your patient to sit in front of you. You ask your patient to open the mouth a little bit and relax the upper and the lower lip. You're gonna take a ruler and you're gonna measure from the stomach, which is the lower part of the upper lip, to the incisal edge position. When the patient is young, around 25 to 35 years old, it's normal without abrasion to have 3 to 5 millimeters of measurement from the stomio to the incisal edge position. When the patient starts to get older, like from 10 to 10 years, it's normal to lose 1 millimeter of the central exposure. I mean, when the patient has 35 to 45 years old, it's normal to have from 2 to 4 millimeters. When the patient has 45 to 55 years old, it's normal 1 to 3. This is really common, and this variation, this difference between 1 to 3, it's about if the patient is a female or a male. Because when the patient is a man, it's normal to have less exposure. I mean, in a young patient, it's normal to have 3, maximum 4. And when the patient is a female or girl, it's normal to have a little bit more. It's more sexy to have more central exposure in the relaxed position from 4 to 5 millimeters. So this is a very nice exam to do. It's just one picture. If you have a situation like I'm showing here in this picture, a young patient with more than 10 millimeters of central exposure, what we usually do, we can suspect that this patient has a vertical maxillary bone axis, but we're gonna combine this with a tomography. We're gonna ask a cranial facial tomography for our patient, and combining those two exams, we're gonna see that if the patient has a vertical maxillary bone axis. As I said, we have two different treatment options for this kind of diagnostics. We can use ortho treatment with a skeletal anchorage, like we did in this case with our orthodontist Erti Silva. We installed mini plates. You can use mini screws. Our preference here is the mini plates. It's a very rigid skeletal anchorage, and by using this skeletal anchorage, we can do by the ortho treatment a vertical movement of this maxilla, and we can create an impact movement to solve this kind of vertical maxillary problem, this vertical maxillary axis problem. So by using these tools in a very good hands, it's a very safe and very nice treatment for the patient. Also, we can do the same by doing orthogenetic surgery, as we did with our surgeon here, Marcos Pita, my great master in maxillofacial surgery. We can do exactly the same. When the patient has a vertical maxillary bone axis, we can do a Le4 surgery, and we can create this impact movement, solving the problem of the vertical maxillary axis problem. So if I have vertical maxillary bone axis, we can do orthogenetic surgery to solve the problem, and also ortho with skeletal anchorage. Another gummy smile diagnostic is the upper lip hypermobility. When the patient comes to you and when you do your videos during the first appointment, and we do this all the time, we always measure from the relaxed position of the lip to the maximal smile. What is normal for the patient? A movement from 6 to 8 millimeters. If I have more than this, like 8, 9, 10 millimeters, I can have a patient with upper lip hypermobility. So how can we solve this kind of problem? I can see two different approaches. One temporary, which is the Botox, which is very good to be temporary, because if you put this kind of medication in the patient and the patient doesn't like the result, you can end this kind of medication after 3 to 6 months, because it's temporary, which is very good. And also it's not very good because it's temporary again, because if the patient likes the result, you will need to do every 3 to 6 months again to solve the problem of the upper lip hypermobility. So we usually use the Botox 1 centimeter away from the nose wing, and also 3 centimeters away from the labial commissure. We do 2 points of Botox here, and maybe sometimes 1 here in the middle, and we can decrease the muscle power of the upper lip lift muscle to create a softer movement of the upper lip. If you want to go for a definitive procedure, you can go for lip reposition procedures. This procedure, it's really described in the literature, work very good in very good hands, but I see in my case some relapses. I see after 1 year, 2 years, maybe 3 years, I see some relapses, so it's better to look for the very nice literature about it and study a little bit more about this procedure to do in a very safe way. So let's move to our diagnostic, to the main topic that I want to discuss with you, which is the crown lengthening procedure. When the patient comes to you with gummy smile and you check that your patient has very short teeth, we can go for the crown lengthening procedure. And when you have a short teeth, we can have two different diagnostics. We can have altered active eruption and we can have altered passive eruption. To understand what is altered, we need to understand what is the physiologic movement. What is active eruption? Active eruption is just the normal movement of the tooth in the direction of the occlusal plane. It's the normal eruption movement of the tooth. And what is normal when the tooth reach the final position in the art? It's normal to have the CJ, the gingival margin at the level of the CJ and the bone normally 2 millimeters away from the CJ. When we have an altered active eruption is when the tooth reaches the final position in the arch, but the bone stays on top of the CJ or maybe sometimes above the CJ, and you have also, of course, a soft tissue access. So we have soft tissue covering the enamel of the patient. So we have a bone access and the soft tissue access. The treatment will be the crown lengthening, removing soft tissue and also doing osteotomy. And what is passive eruption? Passive eruption is not the movement of the tooth now. Passive eruption is the movement of the soft tissue in the apical direction after the tooth reaches the final position in the arch. And what is normal? It's normal when you have the soft tissue at the level of the CJ. When you have an altered passive eruption, is when you have the bone in the correct position, but the soft tissue didn't go to the correct position. You have a soft tissue access. The soft tissue stays on top of the enamel, and the correction will be just removing the soft tissue. Those articles here in the lower part of the screen shows exactly this classification, and it's really easy to communicate. If you have altered passive eruption, it's a problem with the soft tissue movement and you have only soft tissue access. If you have altered active eruption, you have a problem with the bone and the soft tissue during the movement of the tooth in the eruption movement. The treatment will be removing bone and soft tissue. Both we're gonna do the crown lengthening. One just removing soft tissue and the other removing soft tissue and also bone. First thing we need to understand when we're gonna start the crown lengthening, we need to understand which tissue biotype your patient have. It's really important to understand the tissue thickness to do your crown lengthening procedure. So you can ask me, Gustavo, why is it important to understand about tissue biotype to do crown lengthening? Because by understanding your tissue biotype, you're gonna understand how much or how many millimeters you need for the biological width. Biological width, it's something really not new. Biological width was described in 1961 by Gargiulo, and he showed us that we usually, in the average way, we need 3 millimeters from the soft tissue margin to the bone to have space for those structures. gingival sulcus, junctional epithelium, and connective tissue attachment. But 3 millimeters is an average measurement. If you leave, after cutting the tissue, 3 millimeters from the new gingival margin to the bone in all of your patients, in the average way, you're gonna have a stability. But in some patients, you're gonna have recession. In some patients, you're gonna have a small relapse. You're gonna have gingival growth. Why these kind of things happen? Because biological width needs to be related to the tissue biotype, the tissue phenotype. It's important to understand this because when you have a patient with a very thin tissue, you don't need 3 millimeters most of the times. Sometimes we work with 2 millimeters, 2.5 millimeters. Sometimes we go to 3 millimeters. But when the tissue is very thin, 2 to 2.5 millimeters of biological width is more than necessary because we don't need a lot of space for those structures, gingival sulcus, epithelium, junctional epithelium, and connective tissue, because they are too thin and they don't need a lot of space. When you have a very thick tissue, we work with more space. We work from 3.5, 4 millimeters of biological width because we have a very thick structure, so we need more space. And when you have a intermediary phenotype, we work with 3 millimeters. So by checking or by seeing the tissue phenotype of your patient, you're gonna select the distance between the soft tissue and the bone. And how can we diagnose the soft tissue thickness of our patient? I mean, the tissue biotype. The easier way, it's probing our patient. So why this is very easy? Because this is really not expensive. You can do in your clinic without anesthesia, and it's really safe to use. Of course, we have many different techniques in the literature to diagnose the tissue thickness, the tissue phenotype. You can use tomography, we can use the probe test, you can use digital tools. In my opinion, the most easier way is probing your patient. So when you put the probe inside the sulcus, inside the first millimeter subgingiva, and you see your probe shining through the gingiva, you have a thin tissue because the tissue is not thick enough to block the color of your probe. So if you have a thin tissue, you're gonna use 2 to 2.5 maximum space for your biological width. In the other hand, when you put your probe inside the sulcus and you don't see your probe shining through the gingiva, you're gonna have a thick tissue because the tissue is too thick and is blocking the color of your probe. So you're gonna use 3.5, 4 millimeters from the soft tissue margin to the bone, and you're gonna have a stability of your procedure because you're gonna have space for the biological width. You're gonna have space for those structures. So if you are in doubt, you don't see, or maybe you see, you are a little bit in doubt about this color of the tissue, you have an intermediary soft tissue phenotype. So you're gonna work with 3 millimeters. This is really easy to do, and I use all the time in my patients. So if you think that this technique is too empirical, if you think that this technique is too related to the surgeon, you can go and ask for a tomography to your patient. Actually, it's really good to do this in all of our patients. But always you're gonna ask a tomograph with some retractors because you need to remove the superimposed image of the upper lip and the soft tissue. By doing this kind of tomography, you're gonna see everything that you need to see. First, you're gonna see the soft tissue thickness, so you can understand how many millimeters you're gonna leave for your biological width. You're gonna have the gingival margin position, you're gonna see the gingival margin position, you're gonna relate this gingival margin position to the CJ, and you're gonna understand how much you can cut to go and lead this margin to the CJ, and you're gonna have the bone crest level image and also thickness to understand that if you need to remove bone, you're gonna remove bone only in the vertical way or in the horizontal way. So really nice to ask a tomography to do this kind of procedure in a very safe way. Perfect, I know the tissue phenotype of my patient, so I know my biological width. What should I do now? I need to understand one first question. Are we going to restore this patient or not? Because if you are going to restore this patient with veneers, with composites, we can just try to design the future crown of the patient, and I don't need to be aware, or I don't need to worry about the CJ, because if I have a very small root exposure, I'm gonna have easy technique to solve this, because I'm gonna restore this patient. But if I'm not going to restore this patient, my limit is the CJ. I don't want to create to this patient a gingival recession. So really important to understand if the patient is going to restore or not. Second question, what is your reference? How can we go and move to your surgical plan? I'm gonna show 3 different ways that I really like, and 3 different ways that we are using every day in our clinic. So this is the DSD, in the raw way, I mean. The DSD that we use it for a long time, and I'm still using. The technique described by Christian Kochman. What we usually do in the DSD, we take a picture of the face, we realign this picture with the internal picture, and we start to use rulers to do the measurement in a very safe way. And we start to do proportion. Of course, when you do this kind of proportions, I mean, when you do a proportion of 80% of the central incisor, I mean, length and width, we need to take this digital plan, this DSD. We need to check that if I do this, I'm not gonna have a root exposure in a patient that I'm not going to restore. And how do I do this? I go and check in the tomography. I mean, in this kind of patient, I have to create a 80% proportion. I need to go and cut 2 millimeters of soft tissue. I need to take this measurement and go to the tomography and check if I have 2 millimeters of enamel below the soft tissue. If I have 2 millimeters of soft tissue that I can remove if I'm not going to restore. I mean, 2 millimeters from the position of the soft tissue to the CJ. You understand? So I need to relate the DSD to the tomograph to check if it's possible, but it's a very safe way. I can use the mock-up when I'm going to restore the patient, and of course I need to relate also the mock-up with the tomography to check all the measurement. But the mock-up, it's a very nice tool to use, because by using the mock-up, you're gonna have the treatment plan of your restoration, and we're gonna do the bisacryl test again, like we do in when you use a mock-up, and we're gonna use this as our guide because it's on top of the tissue. So that's why it's very important when you are planning to level up the soft tissue, when you are planning to do a crown lengthening procedure, it's important to ask your technician to use wax or to wax up on top of the tissue, or if they are doing in a digital way, it's really important to ask the technician to do this in the digital way also on top of the soft tissue. So you can use this mock-up and use this as a guide. And we can use the surgical guide, which is in my opinion the easiest way to do. And it's really easy because you don't need to relate all the time your plan with the tomography. We're gonna do everything together and you're gonna have a guide that helps you and allows you to do a very safe procedure and really stable, and I'm gonna show step by step how to do it. Showing this patient to you. So this patient came for us and we treated together with Christian Coachman in Well Clinic here in São Paulo. And this patient came with a gummy smile complaining. And we decided to do a crown lengthening procedure because we didn't have, in her case, a vertical maxillary bone access. We didn't have any problem with the lip. We only have problem with the short teeth. So we decided to move for a crown lengthening to make this soft tissue better alignment comparing with the upper lip. So I have a very thick biotype, so by doing the probe test, I didn't see my probe and I selected to this patient 3.5 millimeters of biological width. I mean, I'm gonna cut the soft tissue and I'm gonna need 3.5 millimeters from the gingival margin to the bone. So how can we do this surgical guide? It's for sure my opinion to do this with a very good lab. I'm not a big fan of doing this by myself because if I'm gonna do this by myself, I'm gonna need to stop my time, my clinical time. I will need to buy a printer machine, I will need to buy a software, and I am gonna put a lot of energy to create my line curve of learning how to do this. I need to put a lot of time to rely on all the different informations inside the software to do the plan, and then I'm gonna spend a lot of time and a lot of money to do something that in my opinion it's a lab work. They do faster, they do better, they have experience, and they have the know-how to do these kind of things. So what we usually do, we use the DSD planning center to do it. So I need to send them 3 different exams. I need to send them face pictures, front picture, smile picture, profile picture, smile picture, and 90 degrees picture. Then I need to also send the DICOM file, which is the CBCT. So you ask your patient to do a maxilla tomography, and you ask the lab to send you the DICOM file of this CBCT, and you need a scan of your patient. I mean, you need the STL file of your scan. Combining those 3 files, we send this to the DSD planning center, and then they will plan together with you by doing a share screen conversation. We're gonna use Skype. I'm gonna send everything to them. We're gonna say, okay, let's plan tomorrow at 11 a.m. I open my computer, I dedicate like 10 minutes sharing their screen. They show to me all the planning. I'm gonna say, I want this, I want that. They will do. After that, I just close my computer, I dedicate my time with my patient, treating my patient, and then they send me the guide in my office, which is really nice and easy for me as a clinician. So how can we do this? Let's understand the flow. We are using now Nemo Studio, Nemotech, and as you can see here, we are now superimposing the STL file we're gonna superimpose the tomography, and we're gonna check all these measurements and plan. We're gonna put everything in the face of the patient, so we're gonna see the result. We are now checking new forms. We are now checking like a digital wax up to see the format, to see if the teeth are length enough, if the proportion is okay, and we have the opportunity to check everything at the face of the patient. We see everything. So that's why the pictures are very important. So this is not me doing this. This is the DST Planning Center doing, and I am checking their screen and just saying, okay, I want this and I want that. So after I said, yes, this is perfect, they will just do the guide for me, and the informations that I need to give them is the information about the biological weight. So as you can see here in the pink draw, you see that the biological weight is around 3.5 millimeter as I asked it. And why is important to have the tomography? Because we're gonna take this and now we're gonna go for the tomography, we're gonna superimpose the images, and we're gonna see if we need to open the flap to remove bone. We're gonna see if we need to remove bone in only in a vertical direction or in the horizontal direction. If I have vertical bone axis and also horizontal bone axis, I mean I will see the new gingival margin of my planning, relate this to the bone level, and check if I need to reduce bone because I need 3.5 millimeters of biological weight. So when I have this, I can talk with the patient that I need to open a flap or not, if I need to reduce bone or not, if I going to use burn, if I'm going to use piezo, because I have all the information and I'm checking this with the face, so I don't have any problem with the horizontal level and I don't finish in the wrong way. I know all the treatment plan, I check everything and I talk with the patient and I explain everything that I need to do for the patient. Then when I accept the treatment, I just say to the guys, please print and send to the office. And this is the guide that comes to our office. It's a printed guide, very easy, really nice to use, and I have now the opportunity to try inside the mouth and to have the gingival level incision area and also the bone reduction area, because I have this lack of resin with 3 millimeters, 3.5 millimeters thickness, my biological width. So now it's really easy to remove the soft tissue. After remove the soft tissue, I know that I'm gonna need to open the flap because I saw in the tomography, I saw the planning and the tomography, and I'm gonna reduce the bone by using burrs. So starting cutting the tissue, I have three different options. I can do with a blade, and I can do with a laser, and I can do with electrosurgery. So first of all, let's understand the benefits of those tools. Blade and micro scissor, they are very, very good. Why they are very good? Because they cut and the vascularity after is really good. So the healing is really fast. Laser is also very good, but the problem with the laser is the price. To have a very good laser that cut very, very well the tissue, the price of this tool, it's really not very nice for the clinician. I mean, it's really expensive, but works really good, and the vascularity and the healing after, it's actually very interesting for the patient and for the dentist. The electrosurgery, it's, I mean, the worst when we talk about healing and vascularity after cutting, because It's cutting using heat technology. I mean, it's cutting the tissue by a tool that is gonna decrease the vascularity after. But if you use in a very good way, if you use in a very safe way, it's really comfortable for the dentist. It's really good for the soft tissue cut. It's very fast, and it's a cheap tool. It's a cheap equipment. If I'm gonna talk about benefits, blade and laser, they are better. But the combination between price, easy to use, and also very fast to manipulate the tissue, electrosurgery, in my opinion, is the best tool because it's really safe. I use this more than 12 years. We have literature to support this. You just need to use in a very safe way. Of course, you're gonna decrease the vascularity after, but we need to wait at least 3 months after opening the flap to have a very good healing and then maybe start prosthetic restoration. So there is no problem with that. I don't need a very fast healing after 1 or 2 weeks because it's really not relevant clinically speaking, in my opinion. So I can control very well using electrosurgery. I can finish in a very good way, and I can have a cheap equipment to do. Let's understand how we use this equipment. We can use the blade. What is the problem with the blade? When you cut the tissue, you have bleeding, and you lose a little bit of visual clarity. It's not bad, it's not wrong to use, but in my opinion it's not easy because it starts to bleed, so you're gonna have blood everywhere. And also, it's really not easy to do a very small crown length. I mean, when you need to cut like 2 millimeters, 2.5 millimeters, blades are perfect. But when you need to cut like 0.4, 0.6 millimeter, to use the blade in a very proper way, it's really not easy for everyone. But it's a very good instrument. My opinion, what I like to do, I just mark the tissue with the blood, and then I just take my electrosurge and cut the tissue. I don't need, or I can use this instrument like putting on top of the tissue and stay there forever. I need to be fast with that. But the perfect condition of power, using very fast, and all the time trying to use small cotton balls with cold saline solution to clean the tissue. It's very safe, it's very good. So I like to use the electrosurge because I can control very well and I don't have any bleeding during the surgery. That's why it's really nice to use. After that, we're gonna check all the time with the guide. That's why it's nice to use the guide. We can cut using the guide, which is in my opinion a very good way to do it, or we can just mark the tissue with the blade and then you just cut with the electrosurge. But all the time you're gonna check with the guide if everything is okay, if everything is in position. After that, after cutting the tissue, if I'm doing this in the analog way, I will need to probe. If I don't have 3.5 millimeters from the new gingival margin to the bone, I will need to cut the bone open in the flap, or maybe using a flapless approach when I have a very thin buccal bone. In my case, as I did the planning with the DST Planning Center, I know that I need to do osteoplasty, which is the horizontal reduction of the bone, and also vertical reduction, which is called osteotomy. So I open a normal flap, intrasucular incision, total flap, to start to reduce bone. You see that this patient has altered active eruption because the bone is almost at the level of the CJ. So you need osteotomy, and we have a lot of volume, so we're gonna need a little bit of osteoplastic. So I put the guide again, and I have 3.5 millimeters now to cut the tissue. I start using round diamond burrs, big round diamond burrs, because I'm gonna start to reduce the bone in the horizontal way, create some concavities and convexities around the teeth. We cannot remove bone and create a fenestration or create some kind of bone loss around the tooth. So it's very important to have at least 1.5 millimeter of bone on top of the root, so we don't create any problems with recessions or fenestrations. So we reduce in a very delicate way, create this smooth transition between convexities and concavities between the teeth, and then we're gonna use end cut burr to do our osteotomy, to do the vertical cut of the bone, creating the biological width and creating stability of our procedure, always checking with the guide, which is very important. Look how do we use this end cut burr, and we have some kind of a probe in this burr, so we don't lose the measurement during the cut. And it's really important after doing our osteotomy to finish with a very small round diamond burr to create this smooth transition between the bone and the tooth of the patient. So this is after osteotomy and osteoplastic procedure. You can see that we remove the bone in a very gentle way. We just made everything more smooth, and we cut the bone to have stability. We cut the bone to have 3.5 millimeters from the bone to the soft tissue margin. So now it's time to suture everything to make a very good healing for the patient. So all the time I go to a vertical mattress suture, and I finish this suture in the palatal direction just for aesthetic reason, so the patient doesn't go out with the suture in the front view. So how we usually do these sutures? First step, I go from palatal to buccal direction, taking with your needle the palatal papilla. After that, we go from internal direction to external direction, taking the base of the papilla, as you can see here in the first movement. The second movement, it's from external to internal, taking the tip part of the papilla. It's really important now not to communicate those 2 points with your suture. It's really important to have space between both points, point 1 and point 2, so after you finish the suture you don't create a hole and you lose the suture after that. The third step, it's going back to the palatal direction, but without taking the tissue. Go only for the interproximal area without taking the papilla tissue. Because if you take the papilla tissue, as you can see here in the red number 3, if you take the papilla there, you sometimes create a double papilla healing, as you can see here in the red circle. Because when you take the tissue going back to the palatal direction, the tip part of the papilla, it's gonna move in direction of this in this papilla palatal papilla area, and you're gonna create this double papilla scar. So it's very important to follow everything that I'm gonna say, that I'm saying, because it's really gonna lead you to a very safe procedure. So from palatal to buckle from internal to external, taking the base of the papilla, from external to internal, taking the T part of the papilla, and then going back to the palatal direction without taking the tissue. By doing this, you will see that you're gonna have a very smooth papilla healing. You're gonna have a very delicate papilla suture. So make sure that you are following all the steps to create a very nice healing for your patient. So after finishing this, we are using always monofilament sutures to have a very good healing for the patient. After doing this, we check with the guide again to check if everything is okay, if everything is in position, and we remove the suture after around 10 days. So this is our final result. You see the smile of the patient, everything is working really good for the patient, everything is stable because we did a plan related to the face of the patient in a very safe procedure. I hope you guys enjoyed this presentation. It was a pleasure for me. Thank you so much for your attention.